Now, welcome back to my weekly review of what's new and interesting in the world of endoscopy. Now, this week we have a study, a direct comparison of underwater versus normal endoscopic resections. We have yet another meta-analysis of the full range of CAPS, image enhancement, and even autofluorescence in detecting serrated lesions. We have a prospective multinational study of the use of the shock index, which you may be familiar with. There is a review of serrated lesions and the molecular features leading up to this lesion, type of lesion. We have an update on the molecular features of post-colonoscopy colorectal cancer, which kind of dovetails with the review on serrated lesions. More of that to come. We have a very interesting analysis of where AI is currently in the field of endoscopy, where it's going, and what the research needs to do next, really. We have an update on POEM and reflux, hot topic, and we have a comparison of the English and the Scottish bowel cancer screening program. I've been looking forward to this comparison for ages. There's also a study looking at the musculoskeletal injuries that our trainees suffer in the endoscopy units, presumably. And we finish with a review of infected duodenoscopes and another scary story about dimethicone coating of the biopsy channels of our scopes. So, first of all, though, I should perhaps declare that I'm a bit of a skeptic as regards underwater resection. Now, evil people will say that's because I'm an old fart, but that isn't the reason. The problem is that in my practice it doesn't seem to add that much, really, apart from perhaps in the sigmoid, where it's very cramped and there's no room to inject underneath a lesion. Where there's plenty of space, like in the cecum and the rectum, I don't quite see the point. I feel a bit like the Emperor's New Clothes. Am I the only one who don't get it? Anyway, it was for this reason that I, with some interest, read the article entitled Underwater versus Conventional Endoscopic Resection of Non-Diminutive, Non-Pedunculated. Gosh, the language some people come up with. Non-diminutive, that's kind of larger, and non-pedunculated, that's flattened and sessile. A prospective randomized controlled study, and it was published in GIE in the 16th of October issue by Yen, Lung, and Wilson, who all work in Veterans Affairs medical centers in the US. Now, they compared 462 polyps, and basically half the polyps were removed in the conventional way and half by underwater resection. Both were equally effective at actually removing the polyps, and I guess that ties on to my point. However, the underwater resection was faster. Unexpected. I would have thought it'd be the other way around. For lesions in the 10 to 90 millimeter size, it took on average 2.9 minutes to resect something underwater versus 5.6 minutes to resect it in the conventional way. For lesions larger than 2 centimeters, the difference was less pronounced, 7.3 minutes underwater versus 9.5 minutes in the conventional way. Now, the authors claim that the advantage is faster resection and a cost saving by not having to use a needle or the injection solution. So, removing polyps bigger than 10 millimeter does save you up to 3 minutes of time. It's hardly earth-shattering, is it? That's about the time it takes me to put another clip on. Not sure that this will be enough to entice me to kind of change to underwater EMR. And surely it takes a bit of time to pump that water into the colon and maybe turn the patient into such a position that the water kind of now pools at the site of the polyp. That must take time too. The more I think about this, the more I think that I don't quite believe these results. But then again, it might be because I'm a skeptical old fart. I don't know. Now, on the topic of bowel humbug, I came across another systematic review of distal attachments in endoscopy this time to find serrated lesions. This meta-analysis published in GIE I think at the forthcoming November-ish, actually. We're well ahead of the curve here. It was entitled Improving Serrated Adenoma Detection Rates in the Colon by Electronic Endoscopy, Distal Attachment, a Systematic Review and Meta-Analysis. Now, this distal attachments they included was the endocup, the endocuff, the endo ring, which you might have seen, electronic endoscopy or electronic image enhancement, such as the Olympus narrowband imaging, Pendax eye scan, or the Fujifilm's blue light imaging, as well as the new thing on the block, which is called linked color imaging. They also included autofluorescence, which I haven't heard much about for ages. We actually bought a couple of autofluorescence scopes in Leeds. They cost an extra £15,000, those scopes. And of course, it only takes a tiniest amount of poo in the colon, and you get pink kind of flashing up all over the place, and it's impossible to see anything. It's a bit of a waste of money, I think. Anyway, they carried out a comprehensive literature search along the conventional ways and found 17 studies incorporating some 13,000 people. And basically, to cut a long story short, they found that distal attachments didn't improve detection rates. Surprise, surprise. The use of image enhancement was only linked with a 3 to 7% detection rate, whilst the benchmark for detecting sessile serrated lesion is 15% at the moment. So I don't quite understand this figure. It seems to be lower than you expect to be the benchmark on white light. Anyway, I guess the truth is that endoscopy is divided into those who do believe in a distal attachment and those who don't. And I guess it boils down to the point that we use what works in our hands, don't we? I wasn't entirely surprised that electron enhancement didn't add that much to the mix, really, because we know that the gold standard is actually indiocarmine dye spray after all. And of course, we're all sitting back waiting for the AI revolution to see if the machine can do better than all these things. Now, moving on, in Leeds, when we phone the on-call radiologist in the middle of the night, we get a fantastic service. These guys are heroes. They step in when endoscopies fail, and they manage to stop massive bleeding points and go well beyond what you can expect at 3 o'clock in the morning. We had one patient with a varicose hemorrhage who at 3 o'clock in the morning ended up with a splenic vein stent, a TIPS, and a coiling of all the esophageal varices. Now, if that is not a comprehensive service at 3 o'clock in the morning, I don't know what is. Anyway, it wasn't always like this. 10-15 years ago, the radiologist, if they didn't want to get out of bed, they would start to talk about the shock index. Have you heard about the shock index? It's basically the heart rate over the systolic blood pressure. And of course, you don't want a shock index below 1, because that's when you're tachycardic and hypertensive. Anyway, so with some interest, I read this article called "The Shock Index is Not an Accurate at Predicting Outcomes in Patients with Upper Gastrointestinal Bleeding." It was published in Alimentary Pharmacology and Therapeutics in the October issue by Safuri et al. It was a multi-center study and centers included Glasgow, Denmark, USA, Cornwall, Singapore, and New Zealand. What ties these centers together? I don't know, really. It seemed a bit random, but anyway, the background to this study is, of course, that the NCE pod, the UK National Confidential Inquiry into Patient Outcome and Death, they did a recent report on upper GI bleeding that you might have read, and basically advised that we should use the shock index to stratify patients into high and low risk and kind of predict outcome. But of course, the shock index has never been subjected to a prospective validated study to see if it actually works. So basically, in this multi-center, international study. They recruited 3,000 patients presented with symptoms of upper GI bleeding. The shock index was compared with the standard kind of scoring systems we use to stratify risk, such as the Blatchford score, the pre-endoscopy Rockall score, where you only do half the Rockall score, you don't add the stigmata of the bleeding lesion, the AIM-65 score, and the newly described ABC score. Now, endpoints were for major transfusion, which they defined as needing 4 units or more of blood, or the need for endoscopic therapy and 30-day mortality. Now, out of those scoring systems, the Blatchford score turned out to be the best for predicting need for major transfusion and the need for endotherapy. The shock index was worse than all the other scoring systems for predicting 30-day mortality. So the authors concluded that despite this NCE pod recommendation, there's no clear evidence that the shock index actually is useful at all in predicting outcomes. I must admit that I'm a bit surprised by these findings, because if you have an old person admitted with a heart rate of 120 and a systolic blood pressure of 100, you would have thought that that person would do worse, wouldn't you? One explanation would be that in spite of the large number of patients they included here, maybe only a minority actually were hypotensive from GI bleeding. The others could have been suffered a faint and they came in with vomiting that was mistaken for hematemesis, or maybe they were septic or something. It just seems odd that shock index wouldn't predict mortality. I guess always skeptical when results don't make sense. Now, I do try to make an effort to keep up with the molecular research on colorectal polyps and cancer, and I came across this review here by my friend Iris Nachtigall, which I think means nightingale in English. She's a histopathologist working in Nijmegen, which is in the Netherlands. You must have heard this lady, by the way, speaking at the UEG, or the UEG summer school. She's a pathologist, but she's one of the few histopathologists who can actually communicate clearly with clinicians. The article was entitled Terminology, Molecular Features, Epidemiology and Management of Serrated Colorectal Neoplasia, and was published in Gastroenterology, Volume 157, Issue 4, pages 949 to 966. Oh, there was an American involved too, called Crockett. I don't know him actually. Anyway, it's an excellent review of the topic of serrated lesions, and I particularly like the outline on serrated lesions at the molecular level. Apparently, the first step in the pathway to cancer is a mutation in the gene which regulates something called the mitogen activated proteinase kinase pathway, and this activating mutation, usually in the BRAF gene in serrated lesions, rather than the KRAF gene, which is involved in adenomatous lesions. So this mutation in the BRAF gene gives rise to widespread methylation of genes, and as you probably know, methylation of genes is a bad thing. It switches the genes off, basically. Now, why would you do that? Yeah, seems insane. So why would you silence your tumor suppressor genes, such as the genes coding for P16 or the MLH1 mismatch repair genes? And then the second step is an activation of the VNT signaling pathway, which is some sort of receptor complex sitting on the surface of the cells. Anyway, I read all this and then decided to go back to the beginning and read it again. When I got down to the bottom, and basically Iris said that there are 3 subgroups of colorectal cancers. I thought I skipped that. Anyway, the first group was colorectal cancers with BRAF mutations, loads of methylation silencing of genes. The mismatch repair genes don't work anymore. You end up with lots of weird stuff happening in the genes of these polyps and the cancers. And of course, this attracts a lot of immune cells. And that gives it a surprisingly good prognosis. So in this group you find the Lynch syndrome cancers, of course, because these patients are born with a mismatch repair gene defect. But you also have medullary cancers of the colorectum, which I don't come across much, mucinous cancers, and signet ring cancers of the colon. Presumably all these arise from SSLs and account for up to 8% of cancers. Secondly, there's the cancers which, and this is the smallest group, 6%, they also have BRAF mutations, but these cancers are microsatellite stable. Presumably they also develop from serrated lesions, but somehow they're stable. And then Iris goes on to say, to explain that there's a third group of colorectal cancer, this time with KRAS mutations, so presumably they arise from conventional adenomatous polyps, and they are microsatellite stable and account for up to a third of colorectal cancers. Well, that leaves 2/3 unaccounted for. I thought we had kind of our knowledge had progressed further than this. I'll stop reading at this point. But anyway, keeping in mind this 8% of bowel cancers harbor BRAF mutations and are microsatellite unstable and arise from serrated lesions, then my next study, and this is what I lead me up to, another study on clinical or molecular features of post-colonoscopy colorectal cancers. This was published in Clinical Gastroenterology and Hepatology, actually in the March issue this year, by Samader in the USA. Anyway, the authors remind us that, of course, post-colonoscopy colorectal cancers can happen because they were missed at the original colonoscopy, or because they're so fast-growing, and this is what the authors were hinting at, they're so fast-growing precursor lesions which quickly go from very small lesions to cancers in between surveillance intervals. Of course, there is a third option, and that is that the lesion you found wasn't removed completely and then turns into cancer. That is probably a very large group. Anyway, the study covers a 50-year period in Utah in the USA, and the authors extended the net as much as they could by including cancers developing up to 5 years after colonoscopy. That's a long time. I don't think that I would like to be held responsible for a patient's cancer developing in 5 years' time. That's like me colonoscoping today, and then the patient developing in cancer in 2024, and then somehow I missed that. I don't buy it, really. Anyway, they found 159 post-colonoscopy colorectal cancer. That's 6% of the total number of cancers which they found. But unfortunately, tissue for molecular studies were only available in half of these. Anyway, 1/3 of these precursor cancer of these post-colonoscopy colorectal cancers were microsatellite unstable and therefore likely to arise from serrated precursors. And of course, 1/3 is way higher than the 8%, which it should be. So it's adds to the evidence, the accumulating evidence, that post-colonoscopy colorectal cancers, of course, could be because you didn't remove the lesion in the first place, or you didn't get to the cecum, but it could also be because they arise from different precursor lesions, maybe serrated precursor lesions. Now, one sure way of getting published nowadays is to have the word artificial intelligence or machine learning in the title of your article. I was therefore a little bit kind of anxious about flicking through this article entitled Application of Artificial Intelligence in GI Endoscopy, but it was published by the brilliantly named Robot Engineering Lab in Shandong, China. It was published in the Journal of Digestive Diseases in the October issue this year by Hay and Su. And it's interesting because this was actually published by engineers. So they looked at the research done in endoscopy and concluded that firstly, they concluded that researchers have tended to collect high-quality images, and then they train the system on these high-quality images, but of course they exclude low-quality images, and that's why performance drops in real life or when you use videos. Secondly, most centers would select images and videos with the typical features of a gastric cancer, for example, excluding lesions which were atypical. And of course that leads to selection bias. Thirdly, most studies first develop and train their own AI system, and then they assess them on their own data sets, on their own images. And of course, these training sets and data sets should be completely separate. So you should develop your own kind of data set, and then you should take your AI system and test it on someone else's images. I'm surprised this penny hasn't dropped with people before. And naturally, these issues result in a bit of an exaggerated benefit and disappointment when the technology is brought out into clinical practice. So the authors very, very sensibly concluded that the only way to go at this point is to conduct a multi-center randomized controlled trial to assess the endoscopy's performance in a real clinical setting. Here. And this would, of course, also allow testing for acceptance. I mean, you could see how AI could become intrusive and difficult. It mustn't impact on workflow and your actual procedure. So the integration of AI with endoscopy is also something which is of importance. And I have seen no research on this at all. So this study was interesting because it highlights that there are frontiers still to address, and engineers haven't really gone that far yet. Now, moving on, one of the remaining issues about POEM is, of course, the reflux. Remember that most surgeons would combine the myotomy with a Nissen's fundoplication to reduce reflux post-myotomy. So I was a bit surprised to read this study entitled "Who is at Risk from Post-POEM Reflux?" It was published in Surgical Endoscopy in October 2019 by Arevalo in the USA. Anyway, it was a retrospective review of their 46 cases between 2011 and 2017. They're not all that busy, clearly, with POEMs. Anyway, they had a mean follow-up of only a year. Seems odd, doesn't it? 2011 to 2017, and their average follow-up was only a year. You would have thought it'd be 3 years, having a 6-year interval like that. Anyway, a proportion of patients underwent acid exposure recording by the Bravo capsule afterwards, and they found that 42% of the patients had abnormal acid exposure. Oddly enough, and this is why I mentioned this article, only 13% of patients actually complain of reflux symptoms. Odd, isn't it? So, of course, we know that reflux is common after POEM, but what this is new is that it's difficult to tell who actually needs PPI after a POEM. How do you find these 2 out of 5 patients who do have reflux, which is silent? They don't know they have it. But of course, continued reflux could lead on to Barrett's, perhaps cancers, etc. So you would want to know about reflux, wouldn't you? The only thing that predicted reflux post-POEM was reflux pre-POEM. Oh, it's not rocket science, is it? Now, I've been around for a while. I was actually part of the team that developed the accreditation and ongoing support system for English, the NHS bowel cancer screening program. You might be surprised to hear that the Scots actually decided to go a different way. They didn't want this accreditation system. That was rejected, as I think the Dutch did too, actually. And they decided that there was no need for any particular accreditation for screening colonoscopists. Anyone could do it. So ever since then, I've been very keen to find out how the 2 screening programs compare. Now, tucked away in the journal Colorectal Disease, volume 2019, volume 20, issue 9, pages 0277 to 83, I find an article entitled "Scottish Bowel Cancer Screening Program Scope for Improvement." Promising. Anyway, the Scots, it was published by Aaron Kewen at the University of Dundee and by author from South Tyneside. The data were collected from the Scottish program between 2007 and 2014, and it boils down to this table here, which basically the cecal intubation rates were the same. Cancer detection rate was 2% higher in the English program. The adenoma detection rate, and now to guess it more interesting, was 9% higher amongst the English. Now, the cancer detection rate being 2.6% lower in the Scots, that's actually no longer a quality indicator, because we think nowadays that cancer detection rate is basically a reflection of the background incidence or prevalence rather of cancer. So this study made me think that maybe the fact that there are more cancers and more adenomatous polyps in England is simply a prevalence issue. But then reading in the small print, I read here that apparently the adenoma detection rate in Scotland was higher at the beginning of their screening program, and as the program rolled out and more hospitals were included, the adenoma detection rate dropped. Now in England the reverse has happened. The adenoma detection rate continues to improve, and I think in 2014 the adenoma detection rate was 47.4%. The benchmark being, I think, the guidelines were 35% originally, but the new treatment target is 40% adenoma detection rate. So probably the high adenoma detection rate in England is probably a real finding, and I take credit for that. I think our efforts has now been proven to be worthwhile. Having said that, I wanted to see a few more details. I wanted a comparison of the sedation rates, the polyp retrieval rates, the duration of withdrawal. I wanted more meat on this bone. It's not enough detail here, guys. We want a more detailed analysis. Now, moving on. I remember Brian Saunders and I comparing thumbs, endoscopist thumbs, at a conference in a few years ago, and of course your left thumb takes a hammering with colonoscopy, decades of twiddling firm steering wheels. So that's well known that endoscopists do suffer from musculoskeletal injuries, but very little has been published on it, and even less has been published on trainees and their musculoskeletal injuries. Anyway, this article was published in Digestive Diseases and Sciences, 2019, volume 64, issue 6, pages 1439 to 47, musculoskeletal injuries amongst GI trainees. And basically, it's an American study by Kirsten Austin in the US. She sent out questionnaires to 1,500 gastro trainees. Only 11% replied. Surprisingly poor, isn't it? What are these guys up to? They're too busy to reply to. Well, it was a 29-item survey, so it was quite a lengthy survey. Anyway. Out of those 11% who replied, 20% reported that yes, they did have had suffered musculoskeletal injuries. The kind of issues they had was with the thumb and other hand-related pain in 2 out of 3 trainees. There was no link, surprisingly, with the actual endoscopic weekly workload and the risk of injury. But presumably there's no other explanation. But why otherwise would you hurt your left hand? Other problems reported included wrist pain, tenosynovitis, ankle pain, thumb numbness, and dizziness. I think this is under-researched, isn't it? We should, perhaps in Friends of Endoscopy, we should conduct a similar kind of multinational study to see how common these injuries are. Perhaps they get more common as the decades move on. And how about back and neck problems? I always put my colonoscopy trolley high enough for me to stand straight. Otherwise, you end up with a creak neck. Always put the screen straight ahead of you so you don't look sideways for your when you screen. There are loads of little tricks that we could actually learn from each other about. Moving on, in Leeds, we recently had an outbreak of CPE, which for those of you who are blessed with not knowing what this is, it's a nasty bug, carbapenemase-producing antibacteria, which are resistant not only to carbapenems but also to penicillins and cephalosporins. Now, all our duodenoscopes were quarantined until they all had been cultured and declared free of contamination. And a whole ward had to be relocated from one space to another for what they call deep cleaning. It takes a week, deep cleaning. And all patients coming down from these wards, even if they had been swab negative, they had to be managed as infected patients. It was a huge, huge undertaking. So for this, and if you haven't had CPs at your hospital, it's because you've been lucky. It's going to happen. And I read with some interest this article. It's a review article in Digestive Disease and Sciences by Rahman et al., USA. 2019, volume 64, issue 6, pages 1409 to 18. Duodenoscope-associated infections, an update on an emerging problem. And of course, the duodenoscopes are particularly difficult because they've got the bridge, and which is difficult to clean, of course. So for that reason, newer duodenoscopes have detachable, disposable bridges to help with cleaning. Now, this review basically highlighted something I didn't realize. Pseudomonas aeruginosa is the most common organism. I didn't know that. And because of issues with cleaning, there are supplementary recommendations for duodenoscope processing, which this article kind of is based on. They review all the published outbreaks in which duodenoscopes have been implicated from the last 20 years, and for each outbreak, the organisms, the number of cases involved, the likely reason for the outbreak, the measures taken to combat the outbreak, and the final resolutions were all outlined. And finally, the authors do have some recommendations for this rapidly evolving field. It's a must-read article, really, because all endoscopy units will be affected by CPs, and it's going to be the duodenoscopes that are immediately kind of put in the frame as being suspicious. On the topic of cleaning, and as you probably know, Olympus, Fujifilm, and Pentax all advise against the use of dimethicone added to our rinse water and the back channel water wash. And that's because the dimethicone can end up coating the endoscope channels. Of course, looking at the other side, dimethicone is invaluable in getting rid of bubbles. And if we didn't use it, I think there'd be problems. There'd be missed lesions, definitely, unless you, of course, put it in the colonic wash water, colonic bowel preparation water. But then it will also get into the channels of the scope, because you'd be sucking that water out of the colon, wouldn't you? So that would really get rid of the problem. And you wonder, really, if a little bit of dimethicone inside the channel is such a big deal. Perhaps it makes it easier to clean the scopes. Maybe the water just kind of runs off. Anyway, that's what I thought until I read this article called in GIE, published by Barakat et al. In California, 2019, volume 89, issue 1, pages 115 to 123. Anyway, they compared 3 different concentrations of dimethicone in the wash water: 0.5%, 1%, and 3%. Now, I should say here that in Leeds we add 1 ml, that's 1 pipetful, 1 ml of dimethicone in 1 liter of wash water, and that gives you not a 0.5% solution; it gives you a 0.1% solution. So in Leeds we use an order of 5 times less dimethicone than this study actually covered, way less. Anyway, they then looked at the biopsy channels using this thing called the Stericam borescope. Well, I think I know how that works. Anyway, you put it into the biopsy channel. It's not small enough to actually look at the water jet channel, which is too small, of course. Anyway, they then rinse the biopsy channel and assess the ATP bioluminescence, which is some indirect measurement of the number of organisms in the water. And they found that dimethicone was detectable in endoscopes despite reprocessing, even when it was used in low concentrations, such as 0.5%. There was also more microbes in scopes when more dimethicone had been added, and more moisture. Little droplets could be seen by this inspection. But I guess we still don't know if there are more bacteria and biofilm that develop in these droplets with simethicone than in droplets without simethicone. Maybe droplets are bad just kind of whether or not they have simethicone in them. Now anyway, 2 endoscope washing cycles seem to normalize the fluid droplet count, and the bioluminescence values with dimethicone addition fell to the levels you got without dimethicone added to the wash channel. Of course, the true risk to patients remain, I was thinking at the end of reading this, remains a bit unclear, because it's unknown if this ATP bioluminescence actually translates into an increased risk of bacterial growth and biofilm formation and transmission of infection. Anyway, it still seems sensible to try to minimize the use of dimethicone, and for that reason I will start trying adding only 0.5 ml of dimethicone to a liter bottle. That will give me a 0.05% concentration of dimethicone, which is 10 times less than the lowest concentration used in this study. Not sure if it will be good enough to remove the bubbles though, but it's worth trying. Now the second thing that this study highlights is the issue of drying the scopes. I just wonder if we should try to explore the option of adding an extra long drying cycle to our endoscopes. But then on the other hand, in Leeds, all our endoscopes are cleaned in a central processing unit. They take ages to do it, and to extend the kind of the turnaround times of our scopes further, it might be difficult to kind of fit into the workflow. This is difficult, and at the end of the day, post gastroscopy or colonoscopy infections are incredibly rare, almost unheard of. So you wonder if it's a storm in a teacup. Anyway, that's what we're going to do. And that concludes my review of this week's interesting articles in the world of endoscopy. Thanks for listening.